Welcome to this program on Biomarker-Positive Disease, a personalized approach to selecting targeted therapies in lung cancer and beyond. My name is Dr. Jaime Schneider. I am from the Massachusetts General Hospital in Boston and Harvard Medical School. I am joined by my colleagues, Dr. Solange Peters and Dr. Lizza Hendriks. Our disclosures are listed on the following 3 slides. Our learning objectives today are as follows. We will discuss different molecular assays for detecting biomarkers in lung cancer, including their benefits and limitations. We will apply expert recommendations to interpret molecular testing results and integrate them into clinical practice. We will describe the recent development of targeted therapies and their impact on clinical practice. We will review guideline recommendations for molecular biomarker testing to guide treatment decision-making in patients with non-small cell lung cancer, and discuss best practices of liquid biopsy testing in biomarker-positive non-small cell lung cancer. Here is our agenda for today. This continuing education program is being accredited for 1.25 credits in the U.S. through a joint providership with Postgraduate Institute for Medicine and ACCME. It is also accredited for 1 credit by EACCME for learners in Europe and in Canada. Here is the inclusion statement. This activity is supported by independent educational grants from Roche and Illumina. Thank you for answering the pre-assessment questions already. The same questions will be asked again in the post-test assessment at the end of the webinar. You can share your questions with our expert faculty at any point during the webinar using the Q&A tab shown on the screen. These will be answered during the panel discussion and audience Q&A. Note that the questions will be moderated. I am delighted to introduce you to the first part of this program on the era of precision oncology. When we think about the pillars of cancer care, we often think about historic types of treatment, including surgery, radiation, and traditional cytotoxic chemotherapy. Over the last 2 decades, we have expanded our pillars of cancer treatment to include new paradigms such as targeted therapies and immunotherapies. The development of targeted therapies was really made possible due to our understanding that cancers are a disease of the genome. Cancers are largely a consequence of DNA damage in which somatic gene alterations in tumor cells result in uncontrolled cellular proliferation. We know that inherited genomic changes or germline alterations can cause cancer or influence cancer risk, and that the majority of tumors are known to contain at least one identifiable alteration in the gene. Some genomic alterations, such as mutations in BRAF or gene rearrangement in RET or NTRK, are tissue agnostic and can serve as molecular targets across different types of malignancies. This is really a critical point as tissue agnostic therapies are used to treat cancers based on their genetic and molecular features without necessary regard to the cancer type or where the cancer started in the body. Lung cancer is the leading cause of cancer-related mortality across the globe. But excitingly, treatment of lung cancer have been revolutionized by the implementation of biomarker-directed targeted therapies. We used to only really classify non-small cell lung cancers based on histologic subtype, but over the last 2 decades, clinical genotyping and translational research efforts have enabled the molecular stratification of lung cancers, namely adenocarcinomas, based on the presence of oncogenic drivers. This in turn has spawned the development of multiple targeted therapies matched to their respective oncogene. Over the last 20 years, the field has identified various oncogenic drivers in lung cancer, shown here in green, and shortly after their discovery, this was followed by regulatory approvals, shown in yellow, of biomarker-dependent targeted therapies for patients with advanced disease. When we are performing diagnostic workup of a patient presenting with a new diagnosis of lung cancer, we certainly still do take histology into consideration, but broad molecular analysis for actionable oncogenic drivers is truly critical. And why is this? because we now have an arsenal of approved targeted therapies matched to the respective oncogene that we can use to treat patients. How has this impacted patient outcomes? Well, we know that advances in lung cancer treatments have reduced patient mortality. Population-level mortality rates from non-small cell lung cancer in the U.S. fell sharply from 2013 to 2016, and survival after diagnosis also improved. And why is that? A reduction in the incidence along with treatment advances, particularly approvals for targeted therapies, contributed to the decline in mortality rates. Our first section will focus on biomarker testing in non-small cell lung cancer. Our first polling question is, in your clinical practice, which patient populations do you test for oncogenic driver alterations? I certainly have a high clinical suspicion for oncogenic driver alterations in younger patients with never or light smoking histories, but my practice is to perform broad molecular profiling in all patients with advanced non-small cell lung cancer, irrespective of gender, age, or smoking status. In the first part of this presentation, we will focus on the following questions. What are the criteria that define a good biomarker? What patient population should be tested for biomarkers? Which biomarkers should be evaluated in non-small cell lung cancer? When should biomarker testing be performed? How should biomarker testing be executed? And does biomarker testing have an impact on patient outcomes? So we will start this session with a hypothetical patient case. This is a 62-year-old woman, never smoker, who presented with cough and dyspnea on exertion. Imaging is concerning for metastatic lung cancer. A tissue biopsy confirmed lung adenocarcinoma had a mutation in EGFR at L858. She was started on an EGFR inhibitor, osimertinib, and within 8 weeks, she had significant symptomatic relief and an excellent radiographic response to therapy. So EGFR mutations in lung cancer are often used as a success story to illustrate the impact of targeted therapy. When EGFR inhibitors were first discovered to be effective in patients with EGFR mutant non-small cell lung cancer, the question became whether patients should receive targeted therapy or chemotherapy. This is a list of phase 3 clinical trials of EGFR inhibitors, all of which showed superiority compared to chemotherapy in the first-line setting. So these studies represent a true paradigm shift in the field in which oral targeted therapy agents supplanted chemotherapy for biomarker-positive patients. EGFR, as I mentioned, represents the quintessential biomarker for the use of targeted therapy. So what are the criteria that we think about that define a good biomarker in cancer? Well, we think about tumor specificity, high sensitivity, predictive of response, and the assay should be simple, accurate, and inexpensive. Which patient populations should be tested for biomarkers? Well, biomarker testing is incorporated into national and international guidelines for the diagnosis and treatment of lung cancer as well as other cancer types. Biomarker testing is absolutely critical across different cancer types as we now have targeted therapy options that can be used based on the molecular features of a cancer. Rather than grouping patients by the same tissue type, now we can group them by the same genomic alteration. And here I am showing the timeline of FDA tissue-agnostic approvals. So tissue-agnostic therapies are used to treat cancers based on molecular features without regard to the cancer type or where the cancer started in the body. So for instance, those patients with RET or NTRK fusion-positive cancers, regardless of tissue of origin, can be treated based on their cancer genomic feature. This is emblematic of a shift in the field from tissue of origin to altered molecular pathways, as in the case of NTRK fusion-positive malignancies, which can occur in both adult and pediatric patient populations. Studies have shown histology-agnostic tumor responses to an NTRK inhibitor, larotrectinib, across over a dozen unique tumor types, And this made larotrectinib the first molecularly targeted therapeutic that was approved for use based on tumor biomarker rather than site where the cancer originated. We are now seeing more tissue-agnostic therapies approved, including for oncogenic drivers in NTRK, BRAF, and RET. Beyond EGFR and other biomarkers for which there are tissue-agnostic approvals, which other biomarkers should we be evaluating in non-small cell lung cancer? This is a summary of the timeline of regulatory approvals by the FDA and EMA for targeted therapy agents in non-small cell lung cancer. Given the breadth of these targeted therapy agents, we now routinely evaluate for a diverse set of genomic alterations in lung cancer, and I will highlight here a few key examples. We test for genomic translocations in which a piece of a chromosome breaks off and is reattached to a different chromosome, so that, for instance, gene A and gene B are fused to create an oncogenic fusion protein. In lung cancer, we can observe fusions involving genes ALK, ROS1, RET, or NTRK. We evaluate for single nucleotide mutations, including in genes like KRAS, BRAF, or EGFR. And we evaluate for nucleotide insertions or deletions, such as in the case of EGFR or HER2 exon 20 alterations and MET exon 14 skipping alterations. Some of these genomic alterations I mentioned go beyond lung cancer and are relevant in other cancer types, including in lymphoma, colorectal cancer, glioblastoma, breast cancer, pancreatic cancer, and in the tissue-agnostic context as well. And I want to emphasize here that testing for these biomarkers is critical as it enables the selection of targeted therapies while avoiding therapeutic strategies that are less likely to provide clinical benefit. When should biomarker testing be performed? Generally speaking, the algorithm for treatment of advanced non-small cell lung cancer is as follows. Patient receives a tissue biopsy that provides a diagnosis of lung cancer. Molecular genotyping is carried out in addition to evaluation of PD-L1 status. And if there is an actionable oncogenic driver alteration for which a therapy is approved in the first line, they will go on to receive that targeted therapy agent. So biomarker testing in advanced disease is done certainly at the time of initial diagnosis before initiating treatment to help guide treatment selection or enrollment on clinical trials. Biomarker testing in advanced disease should also be done at disease progression to guide subsequent treatment selection or enrollment on clinical trials. Why does upfront molecular testing matter? Well, a retrospective study showed that unfortunately less than half of patients with advanced non-small cell lung cancer and driver alterations actually received an NCCN recommended targeted therapy. So we absolutely need to do better here. But for those patients with driver alteration, improved overall survival was observed in those who received the recommended MAC targeted therapy versus those who did not. Biomarker testing is also an integral part of the diagnostic workup now in early stage non-small cell lung cancer, including for PD-L1, EGFR, and ALK. There are now approvals in place for adjuvant immunotherapy in early stage lung cancer. And excitingly, osimertinib was the first targeted therapy approved in many countries as an adjuvant treatment for resected EGFR mutant non-small cell lung cancer based on the ADAURA. There is also emerging data for adjuvant alectinib for early stage ALK-positive non-small cell lung cancer. How should biomarker testing be executed? Well, there are multiple considerations in biomarker testing, including test parameters, such as the number of genes tested, type of sequencing methodology, extent of sequencing of an individual gene, DNA versus RNA sequencing. We think about the analyte tested, whether tissue or plasma. And we think about practical considerations, such as turnaround time, sample requirement, insurance coverage, and local availability of a test. There are multiple technologies for biomarker detection, and they have differing abilities to detect genetic variants and protein changes. For instance, FISH is able to identify gene amplifications and fusions, but is not suitable to evaluate single nucleotide variations. So NGS, or next generation sequencing, is a high throughput parallel sequencing approach and a type of broad molecular profiling system that can detect panels of mutations, copy number variations, and gene fusions. In non-small cell lung cancer, the NCCN recommendation is to perform molecular testing via a broad panel-based approach, most typically done through NGS. So for instance, NGS is preferred for detecting EGFR variants because targeted PCR is not able to pick up EGFR insertions or deletions. And more specifically, RNA-based NGS is preferred for detection of MET exon 14 skipping alterations and for fusions. Although NGS is embedded as a recommendation in NCCN, ESMO, and many national guidelines, access to NGS is far from universal. Liquid biopsies that detect circulating tumor DNA, or ctDNA, shed into the bloodstream are becoming an increasingly integral part of the diagnostic workup in non-small cell lung cancer. And although tissue-based testing still remains really the gold standard for tumor genotyping for many cancer patients, ctDNA can be used either sequentially when tumor tissue is insufficient or inadequate for testing, or sometimes concurrently when tissue is scanned or of uncertain adequacy for genotyping. There are several potential advantages of plasma ctDNA, including that it's relatively non-invasive, it can be repeated serially to monitor tumor response or progression. It can sometimes determine mechanisms of acquired resistance to therapy, and it can capture tumor heterogeneity. Using liquid biopsies in early stage disease is certainly a rapidly evolving field. There are some important limitations to be aware of, including that it does not provide histologic information and is less sensitive for certain genomic alterations like amplifications or fusions. And lastly, does biomarker testing have an impact on patient outcomes? And the answer is absolutely yes, it does. A recent report showed that overall cancer mortality has continued to decline in the US because of reductions in smoking, earlier detection for some cancers, and because of the development of biomarker-matched targeted therapies. A retrospective study has shown that improvements in overall survival in patients with advanced non-small cell lung cancer who again received matched targeted therapy for their oncogenic driver. And this was true whether tissue testing was carried out or even with ctDNA testing alone without tissue sequencing. So in summary, targeted therapies have certainly transformed the diagnostic and treatment approaches in cancer. Cancers are increasingly being defined not only by histology, but by molecular genotype. And some molecular driver alterations shape treatment options irrespective of tissue of origin. Broad molecular profiling is critical at diagnosis and at the time of relapse to identify opportunities for targeted therapy in lung cancer. EGFR, ALK, ROS1, RET, NTRK, BRAF, MET exon 14 skipping, HER2, and KRAS are among the oncogenic drivers with approved targeted therapies in lung cancer. And other emerging drivers with targeted therapy options are being evaluated in clinical trials. Efforts are ongoing to move these agents into earlier stages of non-small cell lung cancer, so we need to consider biomarker testing in these contexts as well. And treating patients with matched targeted therapies extends survival and reduces lung cancer mortality. And next, I am pleased to welcome Dr. Hendriks to talk about the evolving landscape of targeted therapies.
Hello, I'm Lizza Hendriks, pulmonologist specialized in thoracic oncology from Maastricht University Medical Center, the Netherlands, and I will give an overview about the evolving landscape of targeted therapies. My disclosures. So the agenda for today. First, I will give an overview about evidence-based strategies for developing targeted drugs. Then I will touch upon biomarker-agnostic targeted therapies and their role in non-small cell lung cancer treatment. And for non-small cell lung cancer, I will go into data analysis and integration in clinical practice to enhance decision-making processes for optimal patient outcomes with consideration of the role of co-mutations and patient-related factors, therapeutic drug monitoring, resistance paradigm, and emerging targets. First, to evidence-based strategies for developing targeted drugs. First, I will start with a polling question. Do you think tumor-agnostic therapies work? Yes or no? Please vote, and then I will tell you my answer. Well, I think it's a little bit nuanced. I think for some tumor-agnostic targets, these therapies indeed do work. So I will show you some examples where it works, and for some where it doesn't work in the upcoming slides. I think first we need to think of what do we want with systemic therapies. Historically, we gave a one-treatment-fits-all to all patients, but now we're into the biomarker space and we want to personalize treatment. Because, and this is already a quite old figure, we know that patients with an oncogenic driver receiving targeted therapy, seen in the Kaplan-Meier and orange, have a longer survival than those with a driver not receiving targeted therapy, in blue. And that's the same survival as patients without a driver without targeted therapy. But if you then move to tumor-agnostic therapy, that's a little bit different than treating one driver and one tumor. Tumor-agnostic therapy is a type of therapy that uses drugs or other substances to treat cancer based on the cancer's genetic and molecular features, without regard to the cancer type or where the cancer started in the body. A tumor-agnostic therapy uses the same drug to treat all cancer types that have the genetic mutation or biomarker that is targeted by the drug. And you can see it depicted in the figures below. So you don't group the patients by the same type of cancer, as is shown in the middle, but you group the patients based on the same genomic alteration, for example, an NTRK fusion. And conventional trials are not feasible in the agnostic setting. There are quite some challenges associated with collecting clinical trial data to assess treatments for rare cancers and rare genomic alterations, such as tumor-agnostic treatments, including the low prevalence of the disease, so small patient numbers. Therefore, it's challenging to identify and enroll patients into clinical trials. And because of the patient numbers are small, often there's a lack of an established comparator in some cases. If you then look into the characteristics that therapeutic agents should have for tumor-agnostic indications, then you can divide it into biological, statistical, and regulatory characteristics. For biological, you need to have an established histology-independent mechanism of action. You need to have an absence of histology-specific mechanisms of resistance. You need to have clinical activity across histologies, efficacy in adults, and if the target is present in kids, also in pediatric patients, and of course clinical safety. Statistical things can be difficult, as randomization might be difficult or not feasible due to the low number of patients, so you need to have an effective design to enable evaluation of subpopulation heterogeneity. And you need to consider the evaluation of a single indication phase 2 data prior to pooling, and responses should be surrogate of clinical endpoints. And for a regulatory standpoint, you need to have a validated biomarker, and you need to show substantial clinical activity leading to belief of superiority versus standard of care. And as numbers are usually quite small, you need to have post-approval efficacy and safety monitoring. And sometimes tumor-agnostic targeted therapies are susceptible to over-application when you extrapolate for use in tumor types not included in a trial based on histology-agnostic therapies. We have some mechanisms to grade the targeted therapies, and we have the ESMO scale for clinical actionability of molecular targets, or ESCAT. And you can see on the figure on the left that tier 1 means ready for routine use, and then it goes down to investigational, tier 2, hypothetical target, tier 4, tier 3, development, tier 5, and lack of evidence, tier 10. And I think for ready for clinical use, if you look at the tumor-agnostic space, then you need to look at level 1C, so below in the table. 1C means that clinical trials across tumor types or basket clinical trials show clinical benefit associated with the alteration drug match with similar benefit observed across tumor types. And the clinical implication means that the access to the treatment should be considered standard of care. But sometimes it's quite difficult to compare the efficacy of cancer therapies between subgroups in basket trials. And I think this publication in Cell Systems has a quite elegant statistical method to evaluate the efficacy of targeted therapies. So This is a quite rigorous approach to permutation testing using empirical null distributions that can identify previously overlooked opportunities for use of targeted therapy in genetically defined cancer types. I think it's a quite interesting article to read to see how you can improve the evaluation of these type of drugs in rare patient populations. Moving then on to biomarker-agnostic targeted therapies and their role in non-small cell lung cancer treatment, I again would first like to start with the polling questions. What are some examples of biomarker-agnostic targeted therapies in cancer? Is this NTRK? Is this RET? Is this BRAF V600? Or is it all of the above? Please vote. And I think for these 3 targets is all of the above. And for the first 2, I will show you some data in the upcoming slides. And there are quite some targets with potential for agnostic drugs. If you look at these types of primary tumors, then you can see that NTRK, RET, BRAF V600, but also MSI high and TMB high are present in different histologies. Focusing on the oncogenic drivers, for NTRK it's mainly found in thyroid and head and neck cancer, but also in non-small cell lung cancer. For RET, it's mainly found in thyroid, and depending on the type of thyroid cancer, it's a fusion or a mutation, or a non-small cell lung cancer, and then it's a fusion. And BRAF V600 mutations are mainly found in melanoma, thyroid, and colorectal, but also in non-small cell lung cancer. And we have quite some tumor-agnostic approvals, starting in 2017 already, with immunotherapy, pembrolizumab, in mismatch repair deficient or MSI-high cancers. Then in 2018, 2019, larotrectinib and entrectinib in NTRK fusion-positive cancers. 2020, 2021, pembrolizumab and dostarlimab, again immunotherapy in TMB-high or mismatch repair deficient MSI-high cancers. And 2022, the dabrafenib trametinib, BRAF V600. And the last one, September 2022, selpercatinib in RET fusion-positive cancer. So what are the data for these approvals? So first focusing on NTRK, larotrectinib and entrectinib. These approvals were based on pooled analysis of phase 1 or phase 2 trials. For larotrectinib over 200 patients and for entrectinib over 100 patients. And you can clearly see in both figures that regardless of the primary tumor histology, these drugs do result in quite deep responses. Response rates are above 60%. And when there is a response, the duration of response is quite long. Median progression-free survival, I think, also very encouraging, and median overall survival either not reached or above 2 years. But I think you should be cautious. These are, again, small numbers, different tumor histologies, so you cannot compare these trials. We even have repotrectinib, also again for NTRK tumor-agnostic, phase 1, phase 2 TRIDENT-1 trial. NTRK negative and NTRK TKI pre-treated, again you can see in both waterfall plots that this drug results in deep and long-lasting responses across different tumor histologies. Moving on specifically to non-small cell lung cancer, again NTRK, larotrectinib and entrectinib, of course smaller numbers, but you can see the same type of waterfall plots specifically focusing on non-small cell lung cancer. Response rates above 60 to 70%, durable responses and encouraging median progression-free survival and median overall survival. But again, because of low numbers, you cannot compare these clinical trials. Moving on to RET, first the tumor-agnostic data for both pralsetinib and selpercatinib. Pralsetinib on the left in the ARROW phase 1-2 trial, and on the right the Libretto 001, selpercatinib. Again, you can see encouraging responses with good duration of response, median progression-free survival a little bit lower, but median overall survival, I think, not bad for these patient populations. For non-small cell, we have even more data. So the ARROW phase 1-2, 75 patients. Here, the treatment-naive cohort with pralsetinib, response rate above 70%, duration of response not reached, median progression-free survival 13 months, and median overall survival not reached. The accelerated lung phase 3 randomizing patients to first-line pralsetinib or chemotherapy with or without immunotherapy is ongoing, but we already have the Libretto 430 trial, a phase 2 trial, evaluating selpercatinib versus platinum-doublet chemotherapy with or without immunotherapy in the first-line setting. And you can clearly see that selpercatinib improves progression-free survival compared with chemotherapy with or without immunotherapy, with high response rates, durable responses, and a median progression-free survival just over 2 years. So, unfortunately, not all are success stories. On the left, you see for non-V600E BRAF mutations or fusions the trametinib data, with response rates of only 3% and a median progression-free survival of below 2 months. In the middle, you see AZD4547 in FGFR, deregulated either amplification or fusions. Again, low response rate, low progression-free survival. And on the right, you see TDM1 and R2 amplified non-breast cancer. Again, disappointing data. So for some of these targets, it could be that it is not the actionable target or that the drug is not working that well. So the key points for this part is that testing for oncogenic drivers is becoming increasingly important across tumor types. And targeted tumor-agnostic therapies work for several oncogenic drivers. RET, BRAF V600 and NTRK have approved therapies, and I showed you the RET and NTRK data, but for BRAF V600 there are also good data, but not all are success stories and continuing research is needed. Moving on to the next part, the data analysis and integration in clinical practice to enhance decision-making processes for optimal patient outcomes. And then I will move and focus on lung cancer clinical practice, because I think for lung cancer, the choice for the right treatment is becoming increasingly difficult with all these new approvals. We have multiple targetable oncogenic alterations, and the development and introduction of these new agents is accelerating, as you can see in the figure on the right. And if you look at the recently published ESMO guideline, we have 10 targetable agents with sometimes multiple options for drugs available, either in first line or in second line. And here are only the EMA and FDA approved agents mentioned, but multiple others are in development. And as we know, for non-small cell, all these targeted therapies result in high response rate. You can see on all these waterfall plots that response rates are high, and I didn't show the data, but responses are durable, and you can see the progression-free survival in the figure. And for some of these targeted therapies, we have long-term survival data. For example, for FLAURA, EGFR, the osimertinib arm, the 5-year overall survival is approximately 40%. For ALEX, the alectinib arm, the 5-year survival is above 60%. For ROS1, crizotinib in the profile 1001, again, encouraging 5-year overall survival of 50%, and the dabrafenib, trametinib, also encouraging long-term survival with 22%. But we know that some patients do not benefit, and we also know that the presence of co-mutations can negatively influence the survival. And here I show you some examples. On the left side, you see the GENIE data for EGFR-mutated non-small cell lung cancer with osimertinib first line. And you can clearly see if the patient had a co-mutation, for example, a TP53 mutation, with or without another tumor suppressor gene, then you can see that the overall survival is clearly inferior to patients without co-mutations. On the right, you see the same for the CROWN phase 3 data, so ALK-positive non-small cell lung cancer, lorlatinib compared with crizotinib in the first line. You can see in blue lorlatinib TP53 negative, the uninterrupted line, and TP53 positive, the dashed line, and the same for crizotinib in green. Again, you can clearly see that patients with a TP53 positive tumor have an inferior median progression-free survival. So maybe we need to escalate treatment in non-small cell lung cancer with co-mutations. And an example of a clinical trial ongoing is a phase 3 trial evaluating olmesartanib with or without chemotherapy in EGFR-positive non-small cell lung cancer with a tumor suppression gene as a co-mutation. And I think in the end we further need to individualize the treatment of these patients based on co-mutations. Brain metastases are also relevant for treatment decisions, and here I show you some examples. We need CNS-penetrating TKI, as you see in the Kaplan-Meier of the figure on the left. The CROWN phase 3 again, the baseline brain metastasis subgroup, so lorlatinib compared with crizotinib first line. And you can clearly see that the patients treated with lorlatinib, so a CNS-penetrating TKI, have a very low cumulative incidence of CNS progression. For EGFR, we know that osimertinib is superior to the first generation EGFR TKI in the treatment and prevention of brain metastasis. But I think quite surprisingly, in the FLAURA2 phase 3 clinical trial, so evaluating osimertinib with chemotherapy versus osimertinib monotherapy in the first-line setting, it was shown that the addition of chemotherapy improved the outcome of patients with baseline brain metastasis, despite the fact that chemotherapy has a relatively poor CNS penetration, and I think more research is needed to explain these outcomes. One of the explanations could be that these patients have a higher disease burden and are in need of a faster response, but I think we don't know it at the moment, and something for further research. Another thing to personalize therapy further in the oncogene-driven space is the use of ctDNA and ctDNA clearance. So on the upper left, you see the FLAURA PFS data based on baseline ctDNA, and you can clearly see that those without detectable baseline ctDNA have a superior survival compared with those with baseline detectable ctDNA. And this holds true for osimertinib, but also for the first generation TKI. If you look at the lower bottom, then you see the FLAURA PFS data based on ctDNA clearance, and again, it's clearly shown that for patients without ctDNA clearance, median progression-free survival is inferior compared to those who achieve ctDNA clearance. And we know for several other oncogenic drivers that similar data exists. And again, this knowledge is used to build clinical trials. So here an example of a clinical trial in the EGFR-mutated non-small cell setting. So patients treated with osimertinib, plasma EGFR testing, and patients who don't clear ctDNA or become positive are randomized to continue osimertinib or are randomized to osimertinib, and then chemotherapy is added, hopefully to further personalize clinical therapy. Another thing I think that's gaining increasing interest is the use of therapeutic drug monitoring. So evaluating plasma levels of the targeted therapy to guide treatment decisions. On the upper left, you see a Dutch clinical trial evaluating whether an intervention in patients with a low plasma level of the targeted therapy results in better outcomes than when there is no intervention. And you can see for the group in red compared to the group in blue that patients with a low plasma level with the intervention to increase the plasma level have better outcomes. However, the other group for patients with adequate plasma levels does have an inferior outcome. And I think the drawback here is that TKI data for non-small cell were largely lacking in this clinical trial. However, if you look at the lower left bottom, then for alectinib retrospective data suggest that a low plasma level is associated with a poorer PFS. And similar retrospective data for crizotinib as well as dabrafenib, but not for osimertinib, exist that low plasma levels are associated with poorer PFS. And again, this data is used to build a prospective randomized clinical trial, and the Dutch ADAPT-ALEC is ongoing. So patients with ALK-positive non-small cell lung cancer treated with alectinib will be randomized to TDM-guided dosing, where the dose is increased if the plasma level is below a certain level, in the absence of unacceptable toxicity or just fixed dosing, and the primary endpoint is median progression-free survival. Then moving on to mechanisms of TKI resistance, we know that they are heterogeneous, and we also know that they can be used to further personalize targeted therapy. So you can have on-target resistance mutations, you can have bypass resistance mechanisms like MET2 amplification. Unfortunately, you can also have histological transformation to small cell or to squamous cell carcinoma, and quite a lot is still unknown. But we know that depending on the mechanism of resistance, we can personalize the treatment for these patients. So for example, for MET amplification, you can give a MET TKI or an antibody-drug conjugate and add it to the EGFR TKI. And in general, the responses are 30 to 40% with a median progression-free survival of 4 to 5 months. But you can also sometimes give antibody-drug conjugates if there is no known targetable resistance mechanism, and these more unselected strategies also result in response rates of 30 to 40% and a median progression-free survival of 6 months. But in the end, these data are mainly derived from single-arm phase 2 trials, and we need randomized clinical trials against standard of care. And fortunately, several are ongoing. There are also new methods of action to enlarge the treatment options and decrease the number of targets. So other targeted therapies, small molecule inhibitors, for example, as KRAS G12C. You can use bispecific antibodies, for example, to EGFR and MET, and antibody drug conjugates, as I already discussed in the previous slide. And one of these new targets is EGFR exon 20 insertion, and here I show you the Papillon phase 3 data. In this trial, patients with metastatic non-small cell and an EGFR exon 20 insertion mutations were randomized to amivantamab chemotherapy or chemotherapy alone, with a primary endpoint of progression-free survival. And amivantamab is a bispecific antibody against EGFR and MET. And as you can see in the Kaplan-Meier curve on the right lower part, the median progression-free survival was clearly superior for the combination of amivantamab chemotherapy compared with chemotherapy alone, with a median of 11.4 months compared with 6.7 months. Another relatively new target is the R2 mutation. Here I show you the Destiny Lung cohort 2 data. So trastuzumab deruxtecan, an ADC against R2, is quite effective in patients with an R2 mutant metastatic non-small cell lung cancer, as you can see in the figure on the right, both in pre-treated and treatment-naive patients. And in the end, I think we further need to personalize therapy and test whether certain targets can be approached in a tumor-agnostic way, or that the treatment should still be based on a tumor type. In the Netherlands, we have the drug rediscovery protocol, so the DRUP. Then we have different drugs, and for each drug, different cohorts are made based on the tumor type and the profile of the patient. And in the end, a couple of patients are treated, and depending whether there are patients with clinical benefit, there are expansion cohorts to see whether the cohort can be declared successful or not. And I think this is a way to develop targeted therapies for rare oncogenic drivers. Another example is the iBasket trial. So that's a modular basket clinical trial that consists of two parts, a profiler part and a basket part. And if you look at the iBasket part, there are different modules based on different oncogenic drivers. And to the best of my knowledge, research results are still awaited. So for non-small cell lung cancer, the key points are that there are an increasing number of oncogenic drivers with targeted therapies available. Patient and tumor-related factors, as I've shown you, play a role or will start to play a role in treatment decisions. And I think upfront broad testing is increasingly relevant to detect all these oncogenic drivers, but also these co-mutations. And I would like again to start a polling question. What do you think is the largest bottleneck for precision medicine? Is this awareness? Is this sample availability? Is this the availability of assays, including costs? Is this timely reporting and interpreting of results? Or is this drug availability? Please vote. And for me, I think there is not a very clear answer. It really depends, I think, on your situation. I think we really should increase awareness amongst physicians that we should start and that we should have broad testing. But sometimes it's difficult to get a good sample. Sometimes liquid biopsy can help. But if you are in a resource-lacking environment, then sometimes assays are not available. Or if you're in a low-income country, cost can be a huge problem. Timely reporting and interpreting of results can be a challenge for some colleagues. And unfortunately, drug availability is not the same across countries, so this can also be a challenge. And I think in the end, we need to work together to improve all these items to increase the access of these targeted drugs for our patients. And with this, I would like to hand over to Dr. Peters.
Dear colleagues, it's my great pleasure to be able to discuss with you today the challenges and the future directions of biomarker testing. This is my disclosure slide. First of all, and probably most importantly, we have to keep in mind that improvements in cancer care and outcomes belong to what we call the SDGs, the Sustainable Development Goals. If you look at this panel, which is at the forefront at the entry of the WHO, you can see under the number 3, this aim of reducing by 1/3 the premature mortality from non-communicable diseases through prevention and treatment that, of course, has taken some delay due to COVID, but remains one of the main goals of the SDGs. And what we speak today about is really related or connected to this improvement in outcome. And we have been hearing that timeline of molecular revolution and personalized precision medicine, non-small cell lung cancer, is about 10 years or even 20 years almost of development, starting in 2009 with the discovery of EGFR mutation, moving in 2013 to ALK, and the series of next biomarkers to be exploited in the decision-making process for our patients. Virtually every new therapy introduced in the last 15 years is allied to pathology and biomarker-driven patient selection. And particularly in adenocarcinoma, addictive oncogenic drivers do make excellent drug targets and excellent biomarkers to be used for this specific strategy definition. This is an example. I could take any other guidelines, the ESMO guidelines, where you can see how much these biomarkers do define a strategy. In frontline, for most of these biomarkers, EGFR, ALK, ROS1, BRAF, RET, NTRK, MET, but also depending on the regulatory authorities and potentially also the reimbursement processes, some of these biomarkers defining only second line for some European countries for NTRK, for HER2 mutation, for EGFR exon 20, and for KRAS G12C. But in front or in second line, whatever they define the patient treatment journey. With ESMO and in collaboration with many of our national societies, we have been performing a survey looking at availability and accessibility to anti-neoplastic medicines. As you can see on the right-hand side, covering most of the WHO regions and coming from low-income to high-income countries, representing altogether 106 countries. Here, just so an example of a table which looks at availability, which is beyond accessibility, also describing how much the drug has or not to be paid by the patient himself. And as you can see, and here we look at drugs which are kind of active, innovative drugs in breast and in lung cancer, EGFR TKIs, as well as some targeted therapies in breast. It's very clear in blue that these drugs are available and free in high-income countries, but they are almost not accessible, and if anything, only out of pocket in low and low middle-income countries. So really showing how the picture is different depending on the various countries studied. So it's quite important because beyond or before the treatment definition, you have the testing issue, of course, and due in part to the availability and accessibility to drugs, you have also very variable testing practices. And they are variable across distinct health systems. And as you can see, this list of what is the ideal testing machinery will vary by continent, by country, by region, and of course also by payer. And the reason why it varies so much, it's because of this, I would say, dependency of clinical need, of course the patient wishes, but more importantly, as I have shown before, there's nothing to be tested if you don't have access to the approved drugs, to clinical trials which gives access to the drug, or to knowledge, awareness, and education around these biomarkers. Of course, some of the limitations are described or encompassed in guidelines, and reimbursement really remains one of the bottlenecks. I just wanted to show some of the guidelines which might guide you also through this decision-making process, and maybe sometimes about the policy discussion. I have shown you the ESMO guideline, but there are many guidelines defining the level of evidence and the needs of biomarker testing across diseases. Just to show you also that the problem of testing is affecting many disease type definitions, many disease type treatment strategy definition, from non-small cell lung cancer to gynecology as well as breast cancer. And as you can see, in every continent you can look at, there's incomplete coverage of the usual biomarker testing, the needed biomarker testing. It's quite important to focus in lung cancer to the data we had, which the data were pretty shocking, I would say surprising at least. For example, my long consortium was showing that overall, if you look at this pretty short list of 5 biomarker tests, they were performed in less than 50% of the overall 3,000 plus patients reported in this series, and almost half of them is just focused on non-squamous, but still half of the patients were missing these 5 biomarkers. So what are the bottlenecks? So I think precision medicine has bottlenecks. And I was speaking before about education, from patient education to sample acquisition. You need a biopsy or sometimes liquid biopsies, but this might be more difficult and less sensitive than tissue biopsies. You have to have access to an NGS assays, bioinformatics, reporting, you need tumor board for decision, and you have to, of course, have the match to an available drug. So all of these bottlenecks really are limiting factors for the incentive or for the motivation and the education around testing. There is one tool that every physician must know, which is the SCAT, which is a framework to be able to rank genomic alterations actionability. And it comes from the tier 1, where you have an evidence-based, I would say the highest improved outcome based on the biomarker assessment that can exist, to potentially the tier 5, where it's not really a meaningful benefit to be proven. And every biomarker will enter one of this category depending on the magnitude of benefit that you have to prescribe accordingly, right? And this tool was developed by ESMO, is used in every ESMO guidelines, but also way beyond at the time being. Thereafter, you can list all of your targets, looking at the prevalence, as the technical ease of testing. Of course, very important, as I said before, the access to therapy, and somehow more subjective, the magnitude of benefit of therapies. And based on that, this is a policy discussion, this is an institutional discussion, and this is also a key opinion leader discussion. We need to, I would say, improve our biomarker testing. Optimizing biomarker testing is based on some statements. First of all, if we could have reflex testing, it would gain time, and it will also gain systematic, I would say, assessment without missing any patients. We like the synchronous testing, if it's possible, not having one mutation but NGS, but in some environments, one gene is still valid if you don't have more drugs. Multiplex testing is not only for NGS and nucleic acid, but it can also be multiplex immunohistochemistry. In terms of choosing of NGS, we like DNA and RNA inputs to be able to see chromosomal rearrangement, but we like also to have large panels, 50, 100 or more. And of course, the inputs, the need from DNA amount or RNA amount will vary according to the methodology. And don't forget, we still need other techniques than NGS, immunohistochemistry, of course, for screening, for example, for fusion genes and expression of protein. And FISH or ISH is still maybe the best approach to count the copy number and judge about amplification of genes. So keep this in mind. What about testing in Europe? So with Gustave Rossi and ESMO, we made an important look at how is a treatment practice, right? How is the treatment predictive biomarker practice in Europe in 2022? As you can see here, we decided to classify the testing into the category of testing, the spectrum of techniques used, which range from single gene technique, as you can see, for example, immunohistochemistry or PCR, to multiple gene technique, NGS, RNA sequencing, whole exome sequencing, whole genome sequencing, and the, I would say, fancy accessory testing like genomic specific assay, tumor mutational burden, as well as liquid biopsy, single, multiple other techniques. So to make a long story short, and yellow is always tested and red is never tested. So 2 examples. For immunohistochemistry, this is widely available. Again, I remind you, we are in Europe, always in routine in the majority of European countries. But when you go to, for example, whole genome sequencing, it's almost not available, and in some countries only for research. If we deep dive into more practical, I would say, consideration, and look, for example, here are some genes, single genes, which may be useful to define strategy in lung and in breast cancer. They are usually always or usually accessible in European countries. But when you look at NGS, for example, or multiple gene techniques, you can see that in most countries it's for research or never available. So single gene versus multiple gene already defines a yellow to red kind of picture. And if you think about the SCAT1, remember the tier 1, so the evidence-based biomarker dictating a better outcome. For lung, in the SCAT1 drug, it's only occasionally tested, sometimes usually tested, and for some of them always tested, but not for all of them. If you look at breast, where you expect an only yellow, you have some of these very SCAT1, very important biomarkers, which are only for research, and only few of them which are always tested. So the SCAT doesn't really support at the time being the right practice or the other way around. So overall, most of the validated biomarkers that can be testing using relatively simple techniques, not requiring extensive panels, are relatively widely tested across all countries, as you can see with the dashed line. But more advanced biomarkers are rarely tested, even if they are SCAT tier 1 outside of clinical trials and research. So that really defines an unmet need, and again, we are in Europe. Very importantly, when you ask the colleagues, do you use genomic alteration scales like the SCAT for actionability? 2/3 of countries report they do not use the one of ESMO, but they do not use any alteration scale actionability scales. And this occurs despite this very important bottleneck and the argument we need for implementation of a systematic testing. What are the types of providers? So basically, the proportion of mostly private provider, meaning private labs, increases with the complexity of the technique. Of course, every country is slightly different in that, and we will further analyze it by country and by region. Who pays for the testing? So again, it's about complexity. The proportion of out-of-pocket expenses for patients increases with, one, the complexity of the technique, so multiple gene techniques, for example, and second, of course, the cost and level of validation and diffusion in the specific health system. This is about recognition by the health system, right? So the more complex, the less probable that it will be paid by a national or a governmental system. And this occurs mainly in countries outside of the EU. So basically, you can really see that in EU, usually we had like the idea that the basis should be covered. Then I would say in terms of limitation of the system, what you would expect is once you have ordered for a general, a limited or a large set of biomarkers, you hope that these biomarkers will be used for treatment decision. And this interesting presentation at ASCO already some years ago was quite worrisome. Is what showing that even when molecular testing is done and done the way it should be done, the optimal treatment is not administered. On the left-hand side, these are patients who were tested having an EGFR or an ALK alteration. And as you can see in the, I would say, clear blue, the immunotherapy was often prescribed in clear blue instead of targeted therapy. And on the right-hand side is when you find an actionable alteration, genomic alteration, you can see in clear blue the proportion of patients receiving the targeted therapy. So 37% receive IO, they should not, and only 45% receive the targeted therapy. So education is really key beyond the policy paradigm in biomarker testing. Last but not least, we all have molecular tumor boards. Some of these tumor boards are focusing on these patients who have undergone all the standards of care and are testing for the discovery of new mutation which might be potentially actionable, SCAT tier 4 or 5, right? There was one trial in France, a profiler trial, examining the feasibility, efficacy, and impact of molecular profiling, large-scale molecular profiling in routine settings after exhaustion of standards of care. This trial led to basically 6% of the patients receiving a matched therapy based on this exploration of new gene activation, actioning on new gene. So 6% received matched therapy based on this kind of exploratory approach for an overall response rate of 0.9%. So basically keep in mind that very large-scale molecular screening should not be used at present to guide decision-making in routine clinical practice outside of clinical trials and, of course, outside of SCAT1, 2, outside of the established treatment paradigms. And with this, my summary, access to innovative anti-neoplastic treatment strategies remain extremely limited and unequally distributed, and it was a global picture. The same holds true for molecular diagnostic testing, and it was more of a European picture. Multiplex parallel testing platforms should be preferred whenever possible. However, simple, essential, dedicated testing assays remain unavailable in many countries, so it's quite important to stress the limitation. If testing is made available, continuous solid medical education is needed for its best use and subsequent treatment decisions. In some regions, a molecular tumor board might create this strong supportive environment which is needed by all of the colleagues. And with this, I think we have looked at the reality of biomarker testing, and I'm very happy to welcome with my colleagues all your questions, your comments, your remarks, entering all together into the discussion around biomarkers. Thanks so much.
Perfect. And now we will move on to the Q&A session. I see that we already have some questions that have been submitted by viewers. And so just a quick reminder, please use the Q&A tab on the sidebar of your viewing screen to submit any questions to us. So now let's get started with our first question from a viewer. So with the FDA and EMA approving adjuvant osimertinib, adjuvant atezolizumab, adjuvant pembrolizumab, and neoadjuvant nivolumab plus chemotherapy for resectable early-stage non-small cell lung cancer, and the recent approval of alectinib for adjuvant treatment in ALK-positive non-small cell lung cancer, how should clinicians integrate these therapies into the current standard of care for patients with resectable early-stage non-small cell lung cancer? Specifically, what factors should guide the selection of adjuvant versus neoadjuvant treatment strategies in these cases? Wow, truly a fantastic question that really hits at the core of what we've been discussing in today's webinar. And so before I ask my colleagues to comment on this question, I will highlight that as the viewer points out, the FDA and EMA did just approve adjuvant alectinib for resectable ALK-positive non-small cell lung cancer just last month in April 2024, giving us yet another targeted therapy option in the adjuvant space. So Dr. Peters, let's hear from you. What is your framework for thinking about different adjuvant targeted therapies versus immunotherapy options for early stage resectable non-small cell lung cancer?
Yes, you ask in one question two very interesting questions. Maybe the first one, which is the essence of your request, is: do we really need to continue to have this, I would say, frontier, this distinction between oncogene addiction and non-oncogene addiction when we come to early disease? So as far as we know, and always with the exception of KRAS G12C, which is a mutation which happens in smoker and doesn't have the same biology of all the other ones found in never smokers. But with the exception of KRAS G12C, the answer is yes. You still have to make a clear barrier, a frontier between these patients who have an oncogene addiction and benefit from a resection as compared to the ones who have not. So all the IO, I would say, components of perioperative or adjuvant trials or even neoadjuvant match, I would say, and fit a landscape which is logically the landscape of EGFR wild type, ALK not rearranged, but probably also the absence of oncogene addiction. So now we have more and more data that in these patients, what you should give instead of IO is adjuvant TKI, EGFR with osimertinib, ALK with alectinib, and maybe suggesting that some well-tolerated other drugs could be used in the same way of alectinib across other oncogene-addicted non-small cell lung cancer. Some of these trials are ongoing. They are sometimes ongoing in very rare disease entities like Rett. However, it's also possible that these trials will never happen, and we will take the opportunity of using the similarity between the drugs, the targets, and the efficacy in a metastatic disease to extend. It might be done in the US, where more freedom can be found in making, I would say, expert-based decision. It might be more difficult in Europe. But I think at the time being, differentiate EGFR mutated and ALK mutated to the other ones. The first group has to have targeted therapy. The second group should have immunotherapy. And if you can, try to make another level of distinction, looking at RET, ROS, NTRK, BRAF, MET, particularly these never smoker patients, but of course, always with the suggestion of oncogene addicted might receive TKI. And if not, questioning yourself, do they really benefit from IO? So that's really something that we need to keep in two groups. So next question, I'm sure Lizza will think about it, is Adjuvant versus neoadjuvant, to my opinion, we have very few data about neoadjuvant TKI. So that really positions the TKI in adjuvant, while the immunotherapy has a lot of question mark about neoadjuvant, adjuvant of perioperative.
Thank you so much, Dr. Peters. Yes, and Dr. Hendriks, I'd love to hear from you how you think about an adjuvant versus a neoadjuvant approach for resectable disease.
I think, well, I fully agree with Dr. Peters, but I also want to do a step back because I'm a pulmonologist by training. And I think before you start treating, you need to make a diagnosis. And historically, quite a lot of patients with non-small cell lung cancer went directly to surgery without a confident pathology diagnosis or a cytological diagnosis with a few tumor cells. And I think we should not accept this anymore. So if you're a medical oncologist, if you don't do the staging and the obtaining of the pathology yourself, you really should discuss with the ones who do the pathology diagnosis, that upfront you should have sufficient tissue, not only for the non-small cell diagnosis, but also for the histological subtyping and PD-L1 and molecular analysis. Because indeed, even if you have a diagnosis of non-small cell, and if you could somehow prescribe neoadjuvant chemoimmunotherapy, I think you could harm some patients if you give it to those with an EGFR or ALK or ROS1 or whatever. So I think all these patients deserve upfront testing. And I think that's a very important message that people should be aware that we should test all these patients. So moving then to the immunotherapy neoadjuvant versus adjuvant, I think there is a preclinical biological rationale to give neoadjuvant. The tumor is still in the patient. The immune system has neoantigens to recognize. It seems that surgery is not more difficult with neoadjuvant treatment compared with just upfront surgery, if you look at the data of the clinical trials. But I think you need experienced surgeons who can also handle, I think, maybe a little bit more vulnerable tissue. In Europe, I think it's easier. We only can give adjuvant immunotherapy to higher disease stages, high PD-L1, and in the Netherlands is even more restricted. So, for example, adjuvant atezolizumab we can only give for PD-L1 high stage 3, and that's it. So if you want to give a patient an opportunity for immunotherapy, then neoadjuvant is, I think, more attractive because the label at least is less restrictive. And I think there is also evidence, at least for stage 2, that immunotherapy works. I think what I like from the neoadjuvant chemoimmuno is that you have a readout of efficacy quite early because you have the surgery. So you know whether the patient has a pathological complete response, which is associated with a very beneficial disease-free survival. You know whether the patient did not respond. So it's also, I think, for communicating with the patient about prognosis, it's easier. And maybe an even bigger question is, if these patients got neoadjuvant chemoimmuno, do they need adjuvant immuno too? So do they need a perioperative regimen? We also now have approved regimens in the perioperative space, and I think we really don't know which patients need adjuvant immunotherapy. Are those the ones that did not obtain major pathological response or no response at all? Would they benefit from more immunotherapy, or will immunotherapy never work for these patients? Or are the patients that benefit from adjuvant immunotherapy those that have a response, but just would have an even better prognosis with adding more immunotherapy? And I know trials are ongoing, for example, within the ETOC in Europe, to try to answer these questions. And I think these are academic questions. Because you can also spare the patient toxicity, you can reduce financial toxicity if you can identify the patients that only need 3 or 4 cycles of neoadjuvant chemoimmuno surgery and then no adjuvant treatment.
Absolutely. Thank you so much, Dr. Hendriks. And this really all speaks to the point that we need to be testing routinely now resectable early stage non-small cell lung cancer at the time of diagnosis, like Dr. Hendriks pointed out, for EGFR alterations, ALK rearrangements, and PD-L1 status that will really help guide treatment options, whether neoadjuvant or adjuvant. Okay, let's move on to another question from a viewer. So this question asks, what is the role of liquid biopsies in difficult or inaccessible locations for lung tissue biopsy? So great question here, asking about sort of the clinical role of liquid biopsies. And I will start off here and say that we are, as a field, increasingly using liquid biopsies to give us information about the tumor molecular landscape, again, both at the time of diagnosis and then at the time of relapse on targeted therapies. And often liquid biopsies can provide this information with relatively quick turnaround times on the order of 1 to 2 weeks, which is sometimes quicker than tissue biopsies. However, I do want to caution here that liquid biopsies cannot give us histologic information. So really still, in my mind, tissue biopsies are still critical at the time of diagnosis because we need to answer questions like, is this a cancer? What type of cancer is it? Is it a lung cancer or something else? And what type of lung cancer is it? Are we talking about small cell or non-small cell, adenocarcinoma or squamous cell? And so we still cannot get that information from liquid biopsies alone. So Dr. Hendriks, I'm curious about your perspective here. How are you using liquid biopsies in your clinical practice? And maybe you can also comment on how you envision ctDNA being used in the future as we think about personalized cancer care. For example, you discussed some trials looking at intensification strategies of treatments based off of lack of ctDNA clearance. So curious to hear your perspective here.
Yeah, lots of questions. I think there's a quite big difference between how I use it and how I would like to use it because of reimbursement issues. And I think in the end, yeah, you also have the financial constraints of your country. So how I use it now is either at first diagnosis of metastatic non-small cell, where we have a tissue diagnosis of non-small cell, non-squamous, but not sufficient tissue DNA for molecular analysis. So then as a rescue strategy, sometimes combined with a new biopsy, because but it takes time to order a new biopsy and wait for the sequencing results of the tissue. And then you can speed up the process if you identify an actionable genomic alteration in the liquid biopsy. Caution, if the liquid biopsy is negative, it doesn't mean that there is no mutation, so something to take into account. Where I mainly use it now is in the EGFR of the TKI progression space, so not specifically the EGFR TKI, where a patient has, for example, slow non-oligo progression, where I do a liquid biopsy to be already informed if there is something that could be targetable in the future with something off-label or a new drug that is approved. For example, we have still some patients on first generation EGFR TKI. If they progress, you hope they have a T790M mutation where you can prescribe osimertinib. Again, if I cannot obtain tissue at progression, then I also try a liquid biopsy. And quite often I try it combined because I think you need to know whether there is an histological transformation. And sometimes it can be additive. So you have some information from the liquid biopsy and some information from the tissue. What I really would like to do, and there are already some trials ongoing and some trials published, if you have a patient with suspicion of metastatic lung cancer, just order everything at once, do a liquid biopsy at first, outpatient clinic visit, order the tissue biopsy, do the staging, and when the patient comes back for at least some results, with a little bit of luck, you have already the molecular results, and you can immediately start treatment. What I also would like to do, but not possible due to financial constraints, is those on TKI have regular liquid biopsies for monitoring, because we know that was the next part of your question. If you don't have a drop in ctDNA, these patients will have a worse outcome than those who do clear ctDNA or who are ctDNA negative in the beginning. You can also use it again to see which resistance mechanisms are emerging. And again, trials are ongoing to see if you have first-line TKI, no ctDNA clearance, then patients are randomized to, for example, adding chemotherapy to the TKI or the TKI alone to see whether it's also predictive for the efficacy of adding chemotherapy.
Yeah, perfect. Thank you so much, Dr. Hendriks. And so due to time, I'd like to just move on to our next question here. From a viewer, how can organizations like the WHO contribute to creating global guidelines for the implementation of lung cancer treatments, and what policies can be proposed to subsidize treatment options globally, given that lung cancer is the leading cause of cancer-related deaths worldwide? So a very important question here, and we did hear about barriers to biomarker testing from Dr. Peters. So Dr. Peters, I'll put this question to you. How can we make headway as a field to improve access to biomarker testing and targeted therapy treatments?
Well, the question is a good one. I mean, I'm not sure it's perfectly addressed the way it should optimally be, because WHO per se is a very big organization looking at health large sense. and other dimensions of health. And they are usually running, I would say, advertisement and campaigns which can endorse and encompass the international variability. So what I mean about lung cancer is they are working quite a lot, of course, all the prevention topic on that, meaning of course, smoking prevention and smoking cessation, and some, of course, capture of data, registry building, supporting also some foundations on the ground. But they are probably not the first, I would say, body to try to look at some continents or some discipline like biomarker testing in lung cancer. They would more campaign about trying to fight against the discrimination against lung cancer research. Remember, the money in lung cancer research is way lower than the one that you can find, for example, in breast cancer, trying to fight against the stigma of lung cancer, which is maybe the reason why there's less money in this field. And of course, also try to campaign in order to make sure that detection is done, screening is done, and declaration is done in order to have a good picture of the country. However, this being said, at every continental level, FDA, as well as Europe with the EMA, we have, and European Parliament, we have some bodies who have in hands the rights to regulate and to potentially convey the messages of efficacy and need. I think in Europe about the Beating Cancer Plan, the BECA, which is based on the European Parliament and led by the European Parliament, which is supposed to really drive the innovation throughout the various topics of lung cancer, particularly testing. And thinking even broader, the IARC, the International Agency for Research on Cancer, which is a branch of WHO, is also an organization which will probably grab and try to handle the description of the variability across countries, particularly about incidence, prevalence, but also what we can do in addition more descriptively. So I think to answer your question, I guess these big bodies, these big organizations help us making sure that we address the right question and that we move the right topic. Then, unfortunately, I think it's still in our bag to make these initiatives brought to the patient at a national level, maybe at an international level in Europe, of course, or regional level, through ESMO, through ASCO, through ACR, through EMA, through FDA, through the European Parliament, to make sure that based on the data this wonderful organization produce, we can really act. And this acting is something which is still missing in many regions of the world.
Great answer, Dr. Peters. Thank you. So with that, we are at time, so we will conclude our Q&A. We have received so many thoughtful questions today, and this has really been a great discussion. I'd like to thank my wonderful colleagues, Dr. Peters and Dr. Hendriks, for joining me today. And I'd like to thank you, all of our viewers, for taking part in this activity. We kindly do ask that you complete the post-activity questions for a short evaluation form today. And your feedback really is critical to help shape future medical education programs. So you can access the link in the Evaluations tab on the sidebar of your viewing screen. Thank you all so much for your attention.